Margaret Higgins is 78 years old, living in an aged care facility. She has vascular dementia, relies on a PEG tube for nutrition, and right now she is in profound systemic distress. Facility staff reported that she hasn't been herself for the past 24 hours. She is presenting with an altered conscious state and intense rigors, signaling a severe, unchecked infection. Looking at the initial ambulance case sheet, we see the immediate threat. She is highly febrile at 38.9 degrees, and her blood pressure has dropped to a critical 94/52. At this pressure, the cardiovascular system is failing its primary mechanical task. It simply cannot generate enough force to push oxygenated blood into her vital organs. To artificially boost that internal pressure, paramedics immediately initiated rapid fluid resuscitation, pushing a 500 milliliter bolus of normal saline. By the time she arrives at the emergency department, she is peripherally shut down. The facility has also notified her primary next of kin, her son, who happens to be a general practitioner. The priority is managing circulatory collapse. Without immediate fluid expansion to restore perfusion pressure, the prolonged hypoperfusion will begin to cause permanent damage to her most vulnerable organ systems. Upon taking over the case, the ED registrar assesses her presentation and recurrent urinary tract infections, diagnosing likely urosepsis with a high risk of acute kidney injury. A presentation this unstable mandates the immediate activation of the hospital's strict sepsis pathway. This diagram illustrates the core pillars of that protocol, which must be executed within the first hour. It requires establishing secure IV access, delivering rapid fluid boluses, drawing blood cultures, and administering broad-spectrum antibiotics. But the file presents a major clinical roadblock. As highlighted in red here, Margaret has a documented penicillin allergy that triggers severe anaphylaxis. This forces the medical team to make rapid risk assessments regarding empiric antibiotic choices. They decide to push stat doses of intravenous gentamicin and cefazolin. While there is a known risk of cross-reactivity between penicillin and cephalosporins, the guaranteed lethality of leaving hypotensive septic shock untreated heavily outweighs the allergy risk. The intervention works at the macro level. After a total of 1 liter of fluid, Margaret's blood pressure stabilizes to an acceptable 112/70. Standard protocols successfully stabilized her systemic blood pressure. However, creating a normal reading on the monitor does not guarantee that perfusion has actually been restored at the cellular level. Margaret is transferred to the medical ward at 12:30 p.m., classified by the handing over nurse as stable but fragile. The formal pathology results reveal hidden, ongoing physiological failures. The top row shows the white cell count elevated at 19.2, confirming a massive systemic immune response. But the real alarm lies in the renal markers. Her creatinine has spiked to 185, and her estimated glomerular filtration rate has plummeted to a critical low of 24. This specific combination of numbers is definitive. Margaret is in stage 3 acute kidney injury. This animation demonstrates the mechanics of septic AKI. When systemic shock caused her blood pressure to plummet earlier in the morning, arterial flow to the nephrons narrowed. Hypoperfusion dropped the internal filtration pressure in her kidneys down to 0, causing severe ischemic injury. Because the biological filtration mechanism stalled out, creatinine, a normal metabolic waste product, rapidly concentrated and backed up into her bloodstream. The rapid ED fluid bolus effectively refilled her vascular pipes, but the actual biological filtration system was already profoundly damaged by the initial hypotensive strike. To understand the true severity of the situation, we have to look past the organ level and examine her actual cellular environment using the venous blood gas. The venous blood gas results display a highly alarming metric. Her lactate level is sitting at 4.8 millimoles per liter. This high lactate tells us her cells are starving for oxygen. To survive, they've abandoned normal respiration, switching to a toxic anaerobic metabolic state. This buildup of lactic acid correlates directly to her blood pH, which is currently acidic at 7.28. Looking at the bicarbonate, we see it is depleted at 16. This cements a diagnosis of severe metabolic acidosis. Her body is trapped in a vicious cycle. It is actively generating lactic acid at the cellular level and lacks the mechanisms to effectively clear it. This compounding acidosis connects directly back to the kidney injury we just identified. The damaged kidneys are entirely failing in their physiological role to filter and buffer this massive acid load. The pathology reveals a different reality than the bedside monitor. While her blood pressure appears stable, these numbers confirm she is actively suffocating at the cellular level. By 2:30, the internal biochemical collapse manifests externally. Margaret is visibly deteriorating in her bed. She develops sudden tachypnea, with her respiratory rate climbing sharply to 28 breaths per minute. Her brain is forcing extreme hyperventilation to blow off carbon dioxide, a physiological attempt to buffer the rising metabolic acidosis. The ward chart highlights a critical physical failure. Over the past 4 hours, her indwelling catheter has drained a total of only 35 milliliters of urine. This state of profound oliguria presents extreme danger. Continuing aggressive fluid resuscitation into kidneys that cannot output urine will rapidly flood her system and cause fatal fluid overload. At the bedside, the clinical crisis is compounded by a severe human factor. Margaret's son is highly distressed and aggressively scrutinizing the nursing staff. He correctly demands a medical emergency team, or MET call, but bases it on a flawed premise. He claims his mother is dying because the hospital has left her dehydrated. While her clinical picture absolutely mandates an urgent MET call, the highly emotional, confrontational environment threatens to drive incorrect decisions. If the team yields to his diagnosis and pushes more fluids, it could prove lethal. The only way to manage a dual clinical and interpersonal crisis of this magnitude is to force communication into a rigid, objective structure. When the MET team arrives, the ward nurse uses the ISO bar handover template as the required cognitive anchor for the room. The handover documents I and S identify Margaret as septic with severe oliguria. Observations and background log her vitals, anaphylaxis, and distressed medically trained son. Crucially, the assessment formally states Stage 3 AKI, using lab results to objectively refute his claim of simple dehydration. Framing the assessment entirely around the venous blood gas and creatinine levels strips the emotional friction from the room and aligns the responding medical team. Finally, the recommendation section outlines exact next steps: escalate medical review immediately, physically assess the catheter for blockages versus intrinsic renal failure, and formally manage the family's distress. Standard protocol-driven resuscitation may stabilize a patient's macro system, but surviving severe sepsis requires clinicians who can recognize microscopic organ failures, resist emotional momentum, and communicate